Welcome to our video on hypercalcemia. Let's begin. For hypercalcemia, we will discuss its definition, pathophysiology, clinical presentation, causes, diagnosis, and management. Hypercalcemia is defined as a total serum calcium greater than 10.5 milligrams per deciliter. Hypercalcemia is most commonly due to a rise in free ionized calcium. It's worth mentioning that even if the patient has normal or high calcium, the total serum calcium may be falsely low in patients with hypoalbuminemia. This is because approximately 40% of calcium is bound to albumin. For every 1 gram per deciliter drop in serum albumin concentration below 4 grams per deciliter, the total measured calcium will decrease by 0.8 milligrams per deciliter. Therefore, one should always correct calcium levels for albumin levels. The formula for calcium correction is the following: the measured total calcium plus 0.8 multiplied by 4 minus the patient's albumin concentration. The pathophysiology of hypercalcemia involves accentuation of the normal processes which raise serum calcium level. So let's first discuss these normal processes. First, sun exposure causes vitamin D synthesis in the skin. Vitamin D goes from the skin to the liver, where it's converted to 25-hydroxy-D3, also known as calcidiol. Calcidiol travels from the liver to the kidneys to get converted into calcitriol, the active form of vitamin D. Calcitriol, in turn, stimulates calcium and phosphate absorption from the GI tract. Second, the main hormone responsible for calcium homeostasis is parathyroid hormone, also known as PTH. Parathyroid hormone is released from the parathyroid glands. Parathyroid hormone then stimulates calcium and phosphate reabsorption from the bone. PTH also induces calcium reabsorption and phosphate excretion from the distal convoluted tubule of the kidney. Both of these processes raise the serum calcium levels. Anything that accentuates these metabolic pathways can potentially induce hypercalcemia. Let's move on to the clinical presentation of hypercalcemia, which is often remembered by the saying stones, bones, groans, and psychiatric overtones. Let's take a minute to break this down. First is stones. Hypercalcemia can cause nephrolithiasis due to hypercalciuria. Increased calcium delivery to the glomerulus increases the calcium filter load. Filtered calcium, on the other hand, binds to oxalate in urine and forms calcium oxalate kidney stones. Next is bones. Hypercalcemia is notorious for causing bone pain. Bone pain is primarily caused by the effect of parathyroid hormone on the bones. Parathyroid hormone decreases the cortical bone mass and induces osteitis fibrosa cystica. This is because excess parathyroid hormone activates osteoclasts, which are bone macrophages. Osteitis fibrosa cystica is characterized by brown tumors. These are the areas of intraosseous hemorrhage, which are later filled with the hemosiderin-laden osteoclasts. Hemosiderin is what gives these masses the brown color. Here you see the X-ray image of the brown tumors present in a patient with osteitis fibrosa cystica. Please note these lucent areas in the bone corresponding to the previous sites of intraosseous hemorrhage. Hypercalcemia is also characterized by gastrointestinal symptoms, which are the groans in our saying. Patients commonly complain of constipation. This is because hypercalcemia increases the threshold potential in excitable tissues and therefore relaxes the GI smooth muscle. Peptic ulcer disease can also occur with hypercalcemia because excess calcium can activate gastric parietal cells, causing gastric acid oversecretion. Finally, hypercalcemia can be associated with pancreatitis. This is because excess calcium levels can activate trypsinogen and other pancreatic proteases in the pancreatic ducts. Consequently, the pancreatic enzymes start to digest the pancreatic tissue. Finally are the psychiatric overtones. Psychiatric disturbances and changes in consciousness are also common in patients with hypercalcemia. Psychiatric disturbances include anxiety and depression. Rapidly rising serum calcium levels can also cause lethargy, stupor, and coma. Severe hypercalcemia can also induce nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus in turn presents with polyuria and polydipsia. The reason for nephrogenic diabetes insipidus in this case is that hypercalcemia causes calcification of the basement membrane of collecting tubule. Therefore, antidiuretic hormone can no longer bind to its receptor and reabsorb free water from the collecting tubule. In addition to nephrogenic diabetes insipidus, patients with hypercalcemia commonly have a shortened QT interval on ECG. Shortened QT intervals predispose the patient to arrhythmias. The reason for QT shortening is that hypercalcemia shortens the duration of the myocardial action potential. Here is an ECG of a patient with short QT intervals. Normally, the QT interval should measure anywhere from 400 to 440 milliseconds. In other words, QT interval usually measures around 10 to 11 small boxes. In this ECG, the QT interval measures 320 milliseconds or 8 small boxes. Therefore, the patient has a shortened QT interval, which can be a consequence of hypercalcemia. Let's talk about the causes of hypercalcemia. Before we move on to specific diseases responsible for hypercalcemia, we should differentiate the most common causes of hypercalcemia in the outpatient and inpatient settings. In the outpatient setting, the most common cause of hypercalcemia is a parathyroid adenoma, while in the inpatient settings, it is malignancy. Now let's discuss specific diseases and the laboratory findings in each of them. Primary hyperparathyroidism is excessive parathyroid hormone secretion due to a parathyroid adenoma, hyperplasia, or carcinoma. Out of these three conditions, parathyroid adenoma is the most common. Regardless of the specific cause, primary hyperparathyroidism is characterized by severely increased parathyroid levels. As we mentioned previously, parathyroid hormone increases serum calcium levels and decreases serum phosphate levels, causing hypercalcemia and hypophosphatemia. Secondary hyperparathyroidism, on the other hand, is excessive parathyroid hormone secretion due to hypocalcemia or hyperphosphatemia. Both hypocalcemia and hyperphosphatemia occur in chronic kidney disease. Chronic kidney disease, in fact, is the most common cause of secondary hyperparathyroidism. Secondary hyperparathyroidism is characterized by hypocalcemia, hyperphosphatemia, and severely increased parathyroid hormone levels. Tertiary hyperparathyroidism is refractory. Autonomous hyperparathyroidism due to reactive parathyroid hyperplasia from long-standing chronic kidney disease. Hypocalcemia and hyperphosphatemia from chronic kidney disease stimulate the parathyroid glands to the point that they become autonomous. Severely elevated parathyroid hormone increases the calcium levels despite the patient having chronic kidney disease. However, serum phosphate levels stay high. Therefore, tertiary hyperparathyroidism is characterized by hypercalcemia, elevated parathyroid hormone levels, and hyperphosphatemia. A 57-year-old woman comes to the physician in an outpatient clinic reporting constipation and diffuse bone pain for the past 5 months. Her lab studies are significant for total serum calcium of 12.5 and high serum PTH. What is the most likely cause of this patient's laboratory findings? So this patient comes in an outpatient clinic reporting constipation and diffuse bone pain for 5 months. Her lab studies are significant for total serum calcium of 12.5 and high serum PTH. These findings are consistent with the diagnosis of primary hyperparathyroidism. The most common cause of hypercalcemia in an outpatient setting is a parathyroid adenoma. In contrast, the most common cause of hypercalcemia in an inpatient setting is malignancy. Let's continue reviewing some etiologies of hypercalcemia. Hypercalcemia of malignancy, as the name implies, is malignancy-induced hypercalcemia. There are 3 main mechanisms by which a cancer can cause hypercalcemia. First, some malignancies can produce parathyroid hormone-related peptide, also known as PTHrP. PTHrP works just like parathyroid hormone. Therefore, PTHrP will also raise serum calcium levels. Cancers producing PTHrP include squamous cell carcinoma of the lung, head, and neck cancer, and so on. Another mechanism for malignancy-induced hypercalcemia is the production of calcitriol. As mentioned previously in this lecture, calcitriol stimulates calcium and phosphate absorption from the GI tract. Therefore, excessive calcitriol production can cause hypercalcemia. Calcitriol is mostly produced by lymphomas. Finally, osteolytic bone metastasis can release calcium from the bone. One of the many examples of the cancer characterized by osteolytic metastases is thyroid cancer of any kind. The common laboratory finding for hypercalcemia of malignancy include high serum calcium and low parathyroid hormone levels. Parathyroid hormone is low due to negative feedback from excessive serum calcium. The other laboratory findings depend on the specific mechanisms of how the malignancy causes hypercalcemia. Some patients may have high PTHrP while others will have high calcitriol. Patients with osteolytic bone metastases commonly have elevated alkaline phosphatase levels. This is because osteoblasts get activated and try to restore the bone. Alkaline phosphatase is one of the enzymes released by the osteoblasts. Familial hypocalciuric hypercalcemia is caused by decreased sensitivity of calcium-sensing receptors to serum calcium. Calcium-sensing receptors are present on parathyroid glands and kidneys, and they regulate PTH secretion in normal amounts. Desensitized calcium-sensing receptors can no longer inhibit PTH production. Therefore, excessive PTH is released in the blood. PTH stimulates calcium reabsorption from the distal convoluted tubule into the blood. Therefore, serum calcium will be high while urine calcium will be low. Serum phosphate levels will be low because PTH induces phosphate excretion. Sarcoidosis is another cause of hypercalcemia. Sarcoidosis is an autoimmune granulomatous inflammation. Macrophages in granulomas can produce calcitriol. Calcitriol then reabsorbs calcium and phosphate from the GI tract. Therefore, patients with sarcoidosis-induced hypercalcemia will have high calcitriol, high calcium, and high phosphate levels. Elevated serum calcium negatively feedbacks the PTH production, so these patients will have decreased PTH levels. Finally, let's discuss medication-induced hypercalcemia. This is hypercalcemia caused either by excessive vitamin D intake or the use of medications like thiazide diuretics. Excessive vitamin D, also referred to as hypervitaminosis D, will present with high calcidiol and calcitriol. Calcidiol is an inactive form of vitamin D synthesized by the liver. Calcidiol is the most commonly measured laboratory test to find out the vitamin D content of the body. Calcitriol, on the other hand, is the active vitamin D synthesized by the kidney. Increased levels of calcidiol will result in production of more calcitriol as long as the patient has normal kidney function. Hypervitaminosis D is also characterized by high calcium and high phosphate due to mechanism that we explained in the previous slide. PTH will be suppressed due to negative feedback from high serum calcium. In contrast, hypercalcemia caused by thiazide diuretics is characterized only by high serum calcium and low PTH levels. Calcitriol and phosphate are typically normal. Let's talk about the diagnosis of hypercalcemia now. We'll start with the laboratory studies. In the serum, one should measure PTH, calcium, and phosphate. Measuring PTH is the most important initial test to differentiate whether the patient has PTH-dependent or PTH-independent hypercalcemia. Calcidiol can be checked to screen for hypervitaminosis. PTH-RP can be ordered if there is high suspicion of hypercalcemia of malignancy. In the urine, one should measure the calcium excretion rate in 24 hours to differentiate primary hyperparathyroidism and familial hypocalciuric hypercalcemia. CAMP can also be used to help distinguish the cause of hypercalcemia. CAMP is the second messenger used by PTH. Whenever PTH works on the kidneys, urinary CAMP increases. Therefore, the patient with PTH-dependent hypercalcemia will have high urinary CAMP, while those with PTH-independent hypercalcemia will have normal or low urinary CAMP. Let's discuss the imaging studies now. Skeletal X-ray can show subperiosteal or subchondral cortical bone resorption in the case of PTH-dependent hypercalcemia. This is because PTH initially starts resorbing the cortical bone. Renal ultrasound or abdominal CT scan can be performed to check for hypercalcemia-related nephrolithiasis. 99M technetium systemibi scan and an ultrasound can localize the parathyroid gland involved in primary hyperparathyroidism. Finally, dual energy X-ray absorptiometry, also known as DEXA scan, is used to screen for hyperparathyroidism-induced osteopenia and osteoporosis. Here you see a skeletal X-ray of a patient with hyperparathyroidism. Please note the subchondral cortical bone resorption evidenced by these loosened areas around the sacroiliac joints. This is a systemibi scan of a patient with parathyroid adenoma-induced primary hyperparathyroidism. You can appreciate increased signal from the left inferior parathyroid gland. This pattern is consistent with excessive PTH production from that particular gland. Now let's move on to management. First, we'll talk about the general management, and then we'll move on to the etiology-specific management of hypercalcemia. Severe hypercalcemia, defined as serum calcium more than 14 milligrams per deciliter, or symptomatic hypercalcemia, are treated immediately with intravenous normal saline and calcitonin. These are short-term measures for severe hypercalcemia. Intravenous normal saline dilutes the serum calcium and alleviates the symptoms. Calcitonin inhibits osteoclast activity and calcium release from the bone. Calcitonin can promptly reduce serum calcium levels. Although loop diuretics increase renal calcium excretion, they should be avoided in patients with severe hypercalcemia unless heart failure with volume overload exists. This is because the patients with severe hypercalcemia are typically severely volume depleted. Administration of loop diuretics will further deteriorate their volume status. The long-term management of severe hypercalcemia is initiation of bisphosphonates, preferably zoledronic acid. Bisphosphonates also inhibit osteoclasts and calcium release from the bone. Moderate hypercalcemia, defined as serum calcium levels from 12 to 14 milligrams per deciliter, requires no immediate treatment unless the patient is symptomatic. If the patient is symptomatic, then moderate hypercalcemia is treated the same way as severe hypercalcemia. Finally, mild hypercalcemia, defined as serum calcium levels less than 12, requires no immediate treatment because it's usually asymptomatic. However, one should avoid medications like lithium and thiazides. Lithium can induce primary hyperparathyroidism. Thiazide diuretics, on the other hand, increase renal calcium reabsorption. Volume depletion should be avoided because decreased volume will concentrate serum calcium and worsen the symptoms of hypercalcemia. Finally, prolonged bed rest can activate osteoclasts, causing hypercalcemia of immobility. This is why prolonged bed rest should be avoided in patients with mild hypercalcemia. A 70-year-old man with past medical history of anaplastic thyroid cancer is brought to the emergency department due to acute confusion. His vital signs are significant for hypotension and tachycardia. The total serum calcium is 16. What is the best initial step in the management of this patient? This patient with past medical history of anaplastic thyroid cancer presents with acute confusion. His vital signs are significant for hypotension and tachycardia. The total serum calcium is 16 milligrams per deciliter. All these findings are consistent with the diagnosis of hypercalcemia of malignancy. Anaplastic thyroid cancer likely metastasized to his bones and caused osteolytic lesions, releasing calcium into the blood. The best initial step in the management of a patient with severe symptomatic hypercalcemia is aggressive intravenous normal saline infusion. Hypercalcemia due to primary hyperparathyroidism can be treated with cinacalcet. Cinacalcet is a calcimimetic which synthesizes the calcium-sensing receptors towards the serum calcium. Sensitized calcium-sensing receptors on the parathyroid gland decreases parathyroid hormone production. As we explained previously, proper hydration is important in the treatment of hypercalcemia. Intravenous normal saline can be used for acute and severe presentations. Calcitonin and bisphosphonates can decrease the calcium release from bone. If hypercalcemia due to primary hyperparathyroidism is refractory to all the other measures, one can perform hemodialysis. The definitive treatment for primary hyperparathyroidism is surgical resection. However, not all patients with primary hyperparathyroidism undergo surgical resection. There are specific indications for parathyroidectomy in the patients with primary hyperparathyroidism. Let's talk about these indications now. A patient less than 50 years of age is eligible to undergo parathyroidectomy for primary hyperparathyroidism because younger patients have longer life expectancy and will better tolerate the surgery. A serum calcium level of 1 milligram per deciliter above the upper limit of normal range is another indication for parathyroidectomy. If the patient's T-score is less than 2.5 at any site, this indicates osteoporosis due to severely elevated PTH levels. Therefore, such patients should undergo parathyroidectomy. If the patient has 24-hour urine calcium excretion rate more than 400 milligrams, he or she should undergo parathyroidectomy as well. Nephrolithiasis is another indication for surgery. Finally, creatinine clearance less than 60 milliliters per minute indicates severe kidney injury from hypercalcemia. Therefore, patients should also undergo parathyroidectomy. Secondary and tertiary hyperparathyroidism are treated with cinacalcet and hemodialysis. Hemodialysis serves to normalize the serum calcium and phosphate levels in order to stop excessive PTH production. Calcitriol, that is active vitamin D, should be supplemented to avoid osteomalacia. Finally, parathyroid glands can be surgically excised in patients with secondary and tertiary hyperparathyroidism. There are specific indications for parathyroidectomy in patients with secondary and tertiary hyperparathyroidism. If the PTH levels are higher than 800, then the patient is eligible for parathyroidectomy. Additionally, if the symptoms persist despite the best medical management, then surgical excision should be performed. For hypercalcemia of malignancy, one should treat the underlying cancer with chemotherapy, radiotherapy, or both. Familial hypocalciuric hypercalcemia usually requires no treatment. Parathyroidectomy is needed in case of atypical features like hypercalcemia-induced pancreatitis. Parathyroidectomy is also done if serum calcium is more than 14 milligrams per deciliter. Asymptomatic patients with sarcoidosis require no treatment. In contrast, Symptomatic patients with sarcoidosis are usually treated with corticosteroids. Medication-induced hypercalcemia is treated simply by discontinuing the medication. Here is an algorithm summarizing hypercalcemia. When a patient has confirmed hypercalcemia, the first test in order to differentiate the cause is serum PTH. Let's focus on the side of the algorithm with low PTH levels first. If PTH levels are low, then we're dealing with the PTH-independent hypercalcemia. Next, we should check the PTH-RP. If PTH-RP is high, then a malignancy workup should be started. In contrast, if PTH-RP is low, then one should consider alternative diagnosis like sarcoidosis and vitamin D toxicity and start the appropriate workup. Now that we've reviewed hypercalcemia with low PTH levels, let's take a look at the other side of the algorithm, which is hypercalcemia with high PTH levels. Once the hypercalcemia with high PTH levels is confirmed, we know we're dealing with the PTH-dependent hypercalcemia. The next diagnostic test to order is serum creatinine. If serum creatinine is normal, then one should order the 24-hour urine calcium. If the 24-hour urine calcium excretion is decreased along with the positive family history of similar complaints, then the diagnosis is familiar hypocalciuric hypercalcemia. If the 24-hour urine calcium excretion is increased along with low serum phosphorus, then the diagnosis is primary hyperparathyroidism. One should localize the source of primary hyperparathyroidism with the 99M technetium system EB scan and ultrasound. If the patient meets the criteria for surgery, then elective parathyroidectomy should be performed. In contrast, if the patient does not meet the criteria for surgery, then conservative management should be initiated. If the patient with PTH-dependent hypercalcemia has high serum creatinine and high serum phosphorus, then we're dealing with the tertiary hyperparathyroidism. Tertiary hyperparathyroidism should be treated either with cinacalcet or parathyroidectomy. A 60-year-old patient comes to the emergency department due to flank pain on the left side that radiates to the groin. He also complains of frequent urination, constipation, bone pain, and weakness. His daughter states that recently he has been irritable. He is a heavy smoker with a 120 pack-year smoking history. Abdominal plain X-ray shows a stone in the left ureter. Lab workup reveals a serum calcium level of 15 milligrams per deciliter and parathyroid hormone level of 3. On exam, his skin turgor is decreased. Shortly after admission, the patient's mental status declined and was managed accordingly. Excessive secretion of which of the following is most likely cause of the patient's symptoms? A. Serotonin. B. ACTH. C. ADH. D. PTHRP. Or E. IL-6. This patient presents with left ureteral kidney stone, frequent urination, constipation, bone pain, and weakness. All these findings suggest hypercalcemia. Hypercalcemia is confirmed by the serum calcium level of 15. Parathyroid hormone is suppressed. Considering his 120 pack-year smoking history, he likely has lung cancer. Lung cancer, specifically squamous cell carcinoma, can release parathyroid hormone-related peptide, also known as PTHRP, and cause severe hypercalcemia. Therefore, excessive secretion of PTHRP is the most likely cause of this patient's symptoms. The correct answer is option D. Here you see the slide reminding us of the mechanisms of malignancy-induced hypercalcemia and the associated laboratory finding. Let's discuss now why other options are incorrect. Option A, serotonin, is incorrect because it is typically secreted in carcinoid syndrome. Carcinoid syndrome, in turn, presents with diarrhea, bronchospasm, and flushing. Option B, ACTH, is incorrect because although small cell lung cancer can release ACTH in a paraneoplastic manner, ACTH causes Cushing syndrome. Cushing syndrome presents with hypertension, hyperglycemia, purple stria, truncal obesity, and so on. Option C, ADH, is incorrect because although small cell lung cancer can release ADH in a paraneoplastic manner, causing syndrome of inappropriate antidiuretic hormone secretion, it presents with hyponatremia. Lastly, option E, IL-6, is incorrect. High levels of interleukin-6 can be seen in multiple myeloma and can cause lytic bone lesions and hypercalcemia. This patient has no signs and symptoms of multiple myeloma other than hypercalcemia. And that concludes our lecture on hypercalcemia.